showing my own data from my own institution as well. Why are children affected? I think this is a very, very logical question, because even a common man would ask you, as a medical student, as a internee, as a trainee, or as a doctor, why is it that children are less affected than adults? I think there are multiple reasons for that.
हेलो सर, आपका माइक म्यूट हो गया सर। सर आपका माइक म्यूट हो गया सर।
Okay, can you hear me now?
Yes, yes.
Okay. I think when you muted everybody, you muted me as well. I think that has been what has happened. Anyway, I think symptoms in children, there are more children who are asymptomatic as compared to adults. And if you look at the data, I think up to 40% of children, even when they are infected, don't know whether they are infected or not. But once they do get infected, the symptoms are quite classical. Fever, cough, shortness of breath, myalgias, rhinorrhea, sore throat, headaches, nausea and vomiting, abdominal pain. Now, I must sort of mention this, particularly the GI symptoms, because the Delta virus is causing more GI symptoms than any previous variant. And of course, if you look at the data, nausea, vomiting, abdominal pain, and diarrhea were there in the previous strains as well, but is more so with Delta virus, which is causing less loss of smell and taste as compared to other variants. Very briefly, I think we have categorized patients with COVID-19 infection. They can be either completely asymptomatic, they can be mildly symptomatic, moderately symptomatic, or severely symptomatic. And I think one of the major ways you differentiate between these different mild, moderate, severe categories is twofold. One, difficulty in breathing without any dangerous signs, and difficulty in breathing with dangerous signs. And of course, radiological evidence, and the most important radiological evidence in this context is if you have the facility of HRCT. If you don't have that, then a chest X-ray and pulse oximetry would help you in deciding whether this is a moderate or a severe case. But all moderate and severe cases need to be admitted in the hospital. What are the isolation recommendations if you get a child who is COVID positive but is not very sick? I think staying at home when sick, don't send these children to school. Repeated hand washing, and I think soap and water, we all know you can use sanitizer as well, but I think in pediatric age group, we would prefer people ask children to wash their hands. Single room and washroom, and of course it's not practical in every house, but wherever it is practical, it must be done if you have a child at home who is COVID positive. Face mask should be worn by everybody, of course by the caregiver as well as the child who is actually sharing the room, but everybody at home must make sure that they are actually wearing masks. You must make a habit and teach the child as how to cough. I think many of us actually don't know how to cough in a public place. And I think this is a good way of teaching your child how to cough in a public place when you teach him at this particular moment. You must dispose of all used tissues instantly. And if any mild symptoms appear, you can treat them with paracetamol and antihistamine, and avoid touching your eyes, nose, and mouth while with unwashed hands. If you see slightest signs of respiratory distress or saturations dropping, the child needs to go to the hospital. Of course, if it's a moderate disease and once they are in the HDU, I think this is beyond the scope of this talk, that I go through the details of what investigations should be done and how should these be treated. But just to give you an idea, if you see a sick child in a moderate illness, they need to be admitted in a hospital. And then, of course, once they are in the hospital, then the pediatrician there would decide when to start steroids, when to give them low molecular weight heparin or any other treatment which is considered a compulsion these days in these patients with COVID-19. Of course, if they get very sick, then they are admitted in an ICU setting. Children's Hospital has been taking all the pediatric patients with COVID-19 since the COVID pandemic has arisen. And I think I must congratulate my entire pediatric team, which have really come on the forefront and has been treating these children, doing ward rounds and managing these patients efficiently in our COVID unit. There are certain drugs which are often talked about, and I think it's important to mention to you that remdesivir has been used in children in controlled hospital environments worldwide. And I think compassionate use of remdesivir and tocilizumab is allowed in certain settings as long as they are not used by a general practitioner or a pediatrician at home or in a setting which is not really geared to look after children with COVID-19. Convalescent plasma has no benefit and has not been shown of any role in pediatric population. Another important thing I think which I must come back is azithromycin. There is no data to show that azithromycin is of any benefit in children. The second reason why pediatric age group has become extremely important is this new disease entity called multisystem inflammatory syndrome in children. We so far has seen 70 plus children only at Children's Hospital with this disease entity in the last year or so. This occurs classically 2 to 6 weeks after the COVID. Majority will be negative for SARS-CoV virus, but will be positive for antibody. And this is the immune dysregulation. It's similar to what historically each one of you must have read about Kawasaki disease. Kawasaki disease is a syndrome where you have conjunctivitis, redness of the tongue, what we call classically a strawberry tongue, along with pharyngeal erythema, and cracking of the lips, rash on the body, swelling and redness of the hands and feet, and unilateral cervical adenopathy. And you need to have 4 out of these following criteria to make a diagnosis of Kawasaki disease. For 50 years, we didn't know what causes Kawasaki disease. But I think today, once the COVID has come in, we definitely know this is a post-viral illness, because more than 1/3 of children with this particular condition, which we call MISC, have symptoms and signs same as Kawasaki disease. Now, how do we define MISC? It is only in children presenting with temperature, symptoms of Kawasaki disease, systemic illness or shock, features of myocardial dysfunction, evidence of coagulopathy, and significant GI symptoms, along with elevated markers of inflammation. So you need to have at least 2 systems involved before you label a child as post-COVID MISC, and you need to also make sure that there is no alternative plausible diagnosis. And one must thing is to get their antibodies done. And you will only label a child as post-COVID MISC once their antibodies to COVID are positive. Clinical features: fever, GI symptoms, feeling unusually tired, Kawasaki disease symptoms like rash, conjunctivitis, non-purulent swelling of lips and tongue, redness of hands and feet, and unilateral cervical adenopathy. Of course, some of them would come in with neurocognitive symptoms, hypotension, shock, acute heart failure, or respiratory symptoms. There's a whole spectrum of the disease. You might see children who are coming to your outpatient clinic just with mild fever, headache, and there may be some systems involved, but because the illness is mild, you may not be admitting them. But the 2 conditions where you need to make sure that you admit these children are: one, which is a presentation of Kawasaki disease, and second, who come in with shock. It's important to differentiate this condition from Kawasaki disease because this tends to occur in older children between 5 and 15. Kawasaki disease occurs in infants and young children. And remember, GI symptoms are very common with MISC. myocardial dysfunction is more common, and inflammatory markers are also significantly more elevated, while coronary aneurysms tend to be less common. This is a classical picture published by our institution. You can see redness of the tongue. You can see conjunctivitis, which can be unilateral or bilateral. You can see redness and peeling of skin from hands, and you can see they are being shown over here. You need to sort of supplement. I wouldn't go into the details of laboratory investigations because that's not the idea of the talk today, but you must go through certain investigations to confirm whether the other systems are involved. But I did two things which are extremely important. One is echocardiography and second is 12-lead ECG. Similarly, managing these patients and recognizing this condition is crucial. And that was the reason I thought I must mention it, even if it is briefly, because the two fatalities which we had at our institution in children with MISC were both late diagnoses. By the time they came to us, they were already in multi-organ failure, and we could not save these children because the diagnosis was delayed. So an early suspicion, check whether there is a history of COVID at home, because majority of them would not have had COVID symptoms, and they need to be treated like Kawasaki disease with IVIG and aspirin, or if they are very sick, then you can give both IVIG and steroids to them. Remember to put them on antiplatelet, either aspirin or they need to be heparinized depending upon their clinical condition. This is a very, very important slide because this gives you the local indigenous data. This is our data from Children's Hospital and University of Child Health Sciences over the last year and a half. Now look at the first wave. We admitted 94 patients in the first wave, 42 children in the second wave, and look at the data on third wave, 208. And then already in the fourth wave, which is the Delta wave, we have admitted 64 patients in just 1 month. So I think it's already on the rise, and it's extremely important that we make sure that children are protected. And the reason I'm saying that is there is a significant mortality. I will be showing you how comorbid conditions contribute to mortality in these patients. Now look at this data. Many of our patients who were diagnosed were either diagnosed pre-operatively or pre-procedure, because COVID screening is a compulsion at our institution. So you can see out of 400 plus patients, 113 patients were those who were never admitted for COVID. They came in for cardiac surgery, they came in for hernia, they came in for achalasia, they came in for some other renal dialysis or some other condition, and when you screened them, they were COVID positive. So I think there are far more children who are COVID positive than what we think. And it's important that we recognize this, particularly in those who have an underlying comorbid conditions. And look at that data, which is again our local data. Of all children which we have treated at Children's Hospital, you can see how many of them had surgical conditions. Cardiac was one of the most common reason for these patients to be admitted. Renal disease was the second most common reason. Then of course, malignancy, particularly tumors, whether it's leukemia, lymphoma, or they are being on steroids or immunosuppressive therapy. And of course, less commonly, pulmonary, neurological, endocrine, GI, and other. But the three most common underlying conditions which make them most susceptible were cardiac, renal, and malignancy. You can see how the surgical conditions, this was more a preoperative screening rather than the otherwise, but these are the three major conditions which were the cause of death in these patients. Lastly, just a couple of minutes about vaccine. I think we know that Pfizer-BioNTech vaccine is approved for children. So is Sinopharm, which is the Chinese vaccine, which we have been giving to people in this country. Vaccine under 12 will be approved late this year or early next year, because there are trials going on in USA and other countries. And I think the time is not far off when we will be vaccinating all children, including neonates. And I think we have already seen that it's safe. The vaccine safety data is already there, and that is clearly showing that it can be given in pediatric age group. This is Pfizer-BioNTech vaccine data from children, 3 trials. They enrolled to 22,000 children, 2,260 adolescents, 100% efficacy and robust antibody response. And vaccines were very well tolerated in these patients under 12. There's some questions which people ask. Can you give it when the girls are menstruating? The answer is yes. Can they be given with COVID? Can other vaccines be given? I think the initial stance was to have a gap of 2 weeks, but I think no gap is now required. You can give them concomitantly with other vaccines. Any contraindications? I think unless you have a history of allergy, there's no contraindication. Any differences in ingredients of adult or kid vaccine? The answer is no. The dose is the same. The material is the same. Why do kids need it? If they don't have severe illness, I think you need to prevent severe illness, particularly in children who have a comorbid condition. What are the side effects? You can see the similar side effects. I think one thing which has been highlighted in the literature, and I thought I must mention that, is myocarditis and pericarditis. The risk is only 1 in 30,000. So it's extremely rare condition. It's not life-threatening. And the only symptoms these children get are chest pain, shortness of breath, fluttering, and pondering hard. In Pakistan, I think vaccination program has already started. We are giving it from 16 to 18, those who are travelers. We have already on the forum of CIAG recommended to the government that it should be given to all children above 12. But I think because we have so many adults still who are not being vaccinated, that's why the government has not come to pediatric age group at the moment. But we are already pushing on the forum of CIAG that pediatric age group needs to be vaccinated as well. This very recent data from India, where they have made first DNA plasmid vaccine for pediatric age group between 12 and 18. It's a 3-dose. It has been approved for emergency use in India. And I think DNA vaccines are generally, they don't require ultra cold storage. So for countries like Pakistan, I think they are excellent.
And we will restart.
I would like to finish by saying that COVID-19 in children is generally mild with good outcome. Underlying comorbid conditions are a major risk factor for prolonged hospital stay and a poor outcome. So you must recognize these children. We must be able to have a high index of suspicion to diagnose multisystem inflammatory disease. Delta variant is affecting more children than the previous 3 waves, but it's not alarming.